Welcome to the lit review of dilated cardiomyopathy. Learning objectives. By the end of this lecture, you will be able to define dilated cardiomyopathy, understand the differential diagnosis and evaluation of dilated cardiomyopathy, and be able to describe the treatment of dilated cardiomyopathy. To meet the learning objectives, we will start with the patient case, followed by a discussion about the definition, causes, evaluation, and management of dilated cardiomyopathy. Let us start with our case. A 48-year-old male with no past medical history comes to clinic with several weeks of dyspnea on exertion and fatigue. He denies chest pain, but did have a viral illness 2 weeks prior to the onset of symptoms. He takes no medications and has no family history of cardiac disease. On review of systems, the patient endorses orthopnea and paroxysmal nocturnal dyspnea, but otherwise has no complaints. Physical exam is notable for a blood pressure of 100/60, heart rate of 80, a displaced apical impulse, S3 gallop, jugular venous distension of 12 centimeters, faint rales at the lung bases, and 2+ pitting edema of the lower extremities. What is the next step in diagnosis and management of this patient's underlying condition? This gentleman has a history and physical exam findings suggestive of heart failure, including orthopnea, paroxysmal nocturnal dyspnea, S3 gallop, and volume overload. In a young person with new onset of heart failure and a displaced apical impulse suggesting an enlarged heart, dilated cardiomyopathy is an important consideration on the differential diagnosis. Dilated cardiomyopathy is defined as enlargement of one or both ventricles, often associated with systolic dysfunction. As the cardiac chambers dilate, they lose their ability to optimally eject the blood inside of them, which leads to a depressed ejection fraction. Dilation of heart chambers often precedes the onset of symptoms of heart failure. The evaluation of dilated cardiomyopathy starts with a thorough history and physical exam, trying to identify the underlying cause or risk factors for development of the condition. Dilated cardiomyopathy is a heterogeneous disease with many potential causes. An exhaustive list would be difficult to compile. Nevertheless, there are major categories of disease that should be considered when anyone is given a new diagnosis of dilated cardiomyopathy. These include ischemic heart disease, infections, endocrine disorders, metabolic or nutritional deficiencies, genetic disorders, valvular heart disease, toxin or drug-mediated cardiomyopathy, and other causes such as cardiomyopathy secondary to rheumatologic disease, infiltrative disease, or peripartum cardiomyopathy. Your history and physical exam should help guide your differential diagnosis and next steps in diagnostic workup. For instance, if the patient has a strong family history of dilated cardiomyopathy, then genetic disorders and environmental exposure should be investigated. In a patient with a recent viral illness, viral myocarditis could be expected. Patients with valvular heart disease would be expected to have murmurs on exam, and so on. The next steps in the diagnostic workup are highly dependent on the differential diagnosis, so a thorough history and physical exam are the cornerstone of the evaluation of dilated cardiomyopathy. Identifying the cause of dilated cardiomyopathy is important because treatment and prognosis in dilated cardiomyopathy can vary widely depending on the underlying cause of cardiac dysfunction. In a study of 1,230 patients with dilated cardiomyopathy, peripartum cardiomyopathy carried the best prognosis, whereas cardiomyopathy due to infiltrative diseases and HIV infection portended poor long-term prognosis. As mentioned before, the most important component of the evaluation of dilated cardiomyopathy is a thorough history and physical exam. Often, patients will present with signs and symptoms of heart failure. Anyone with a suspected diagnosis of new onset heart failure or dilated cardiomyopathy should have a 12-lead electrocardiogram, transthoracic echocardiogram, chest x-ray, and basic serum chemistries performed. This includes a complete blood count with differential to assess for potential infectious or infiltrative disease, basic metabolic panel to assess renal function, thyroid stimulating hormone to rule out thyroid diseases as a reversible cause of heart failure, urinalysis for any clues such as red cells or proteinuria that would point towards investigating systemic process, and liver function studies to assess for congestive hepatopathy and for a globulin gap. Additional testing is dependent on history and physical exam. For instance, if someone has a history that strongly suggests ischemic heart disease such as angina or chest pain, then they should undergo coronary angiography. An HIV test may be indicated in individuals with appropriate risk factors. Cardiac MRI is helpful in diagnosing a variety of cardiac diseases, including infiltrative diseases, though its use is sometimes limited due to cost or availability. Depending on clinical suspicion, a genetic or rheumatologic investigation can be performed, though these studies should only be performed in persons where there is strong suspicion for genetic or rheumatologic disease because the cost of such testing is high. Endomyocardial biopsies should not be routinely performed in the evaluation of dilated cardiomyopathy. This is a procedure where a transvenous biopsy of the right ventricle is obtained with the use of a biotome inserted through the internal jugular vein. This procedure is generally reserved for those instances where there is suspicion for infiltrative disease, since most other diagnoses can be made without the use of invasive testing. Treatment of dilated cardiomyopathy should address the underlying cause of the cardiomyopathy if possible. For instance, patients with nutritional deficiencies or endocrinopathies should have their primary disorder corrected, and patients with underlying coronary disease should have revascularization of any viable myocardium. Nevertheless, the cause of dilated cardiomyopathy is not discovered in 50% of cases, and many known causes of dilated cardiomyopathy have no specific treatment for the underlying condition. Regardless of underlying cause, treatment of dilated cardiomyopathy should also include treatment of chronic heart failure, including the use of drugs and interventions that are known to reduce mortality in heart failure. These include ACE inhibitors, angiotensin receptor blockers for patients intolerant to ACE inhibitors, beta blockers, aldosterone antagonists, hydralazine and nitrates in African Americans, and primary prevention implantable cardioverter defibrillators in patients with sustained ejection fraction of less than 35% despite optimal medical therapy. Diuretics should of course be given for symptom management and treatment of volume overload, and lifestyle modifications including strict limitation of salt intake should be instituted. For patients with severe cases of dilated cardiomyopathy, advanced heart failure therapies may need to be offered. These therapies are generally reserved for patients with class 4 heart failure symptoms despite optimal medical management. There is a burgeoning body of literature regarding the use of ventricular assist devices for long-term or even indefinite hemodynamic support for patients with severe symptomatic heart failure. A ventricular assist device provides mechanical support to either the left or right ventricle by literally pumping blood from the ventricles into the circulation. A right ventricular assist device would pump blood from the right ventricle into the pulmonary circulation, and the left ventricular assist device would pump blood from the left ventricle into the aorta and systemic circulation. Ideally, implantation of a ventricular assist device supports cardiac output to meet the demands of the body and allow a patient's symptoms of heart failure to be controlled. Cardiac transplantation may be considered in select individuals with severe heart failure. However, cardiac transplantation is a limited resource, so patients must meet strict criteria for transplantation. Moreover, transplantation itself is associated with a number of risks and comorbidities, including use of immunosuppressive drugs and risk of organ rejection. So the decision to transplant a patient for dilated cardiomyopathy must be made by teams of experts with experience in cardiac transplantation. Inotropic therapy, including agents such as milrinone, dobutamine, and dopamine, have fallen out of favor except in certain circumstances. The use of inotropes has not been shown to provide a mortality benefit in the treatment of chronic heart failure, and in fact has been shown to cause harm in a number of studies. Therefore, use of inotropes should be limited to providing hemodynamic support in patients with decompensated heart. To summarize, let us revisit our patient case, and let us assume that this patient has no other pertinent history or exam finding. What do you think are the next steps in diagnosis and management of this patient's underlying condition? Again, the key in evaluation of dilated cardiomyopathy is the history and physical exam. This patient likely had viral myocarditis and consequent dilated cardiomyopathy since he has a clinical presentation of heart failure and had a recent viral prodrome. Initial evaluation should include a 12-lead EKG, transthoracic echocardiogram, complete blood count, basic metabolic panel, thyroid stimulating hormone, liver function studies, urinalysis, and a chest x-ray. Since this patient has no anginal symptoms, coronary angiography can be deferred at this time. Moreover, there is no indication for genetic testing since he has no family history of cardiac disease, and testing for additional endocrinopathies, metabolic causes of cardiomyopathy, and for rheumatologic disease is not indicated at this time because the patient has no findings to suggest he has any of these causes for his dilated cardiomyopathy. Management at this time would include initiation of a diuretic for symptom management with addition of neurohormonal therapy with ACE inhibitors, beta blockers, and aldosterone antagonists as tolerated. If so, despite optimal medical therapy, the patient's heart failure progresses or fails to improve, consideration could be given to advanced heart failure therapies. In summary, dilated cardiomyopathy is a heterogeneous set of disorders characterized by a poorly functioning dilated ventricle. Prognosis varies widely depending on the underlying cause of dilated cardiomyopathy. The history and physical should guide your diagnosis and management plan. and you should be aware of the minimum investigation required to assess for reversible causes of dilated cardiomyopathy. Treatment of dilated cardiomyopathy involves correction of any reversible causes, in addition to optimal medical management of heart failure. If medical management fails, advanced heart failure therapies may need to be considered. This is a list of key references. And this concludes our review.